Okay, let's get started. Welcome, everyone, and thank you for joining us for the Elders Climate Action July National Call. I'm Frances Stewart, a volunteer with Elders Climate Action and chair of the Education Committee. I'm grateful for the opportunity to moderate today's call with our renowned guest, Dr. Haines, who I want to introduce in a little bit. For those of you who are new to Elders Climate Action or may never have heard about us, we always like to say that we are great uncles and great aunts, grandparents, and everyday folks who are determined to do all we can to leave a livable planet for future generations and for all life. Our programs, communications, and chapters are focused on engaging elders in building the personal and political will needed to respond to the climate crisis. At Elders Climate Action, we are elder-centered and volunteer-driven, seeking to inform, inspire, engage, and encourage older generations to take action on the climate crisis at the local, state, and national levels. About 5 months ago, ECA's climate and health team gathered with a connect the direct impacts of climate change with our health. Members include health professionals and many others with an interest in healthcare. Current and retired doctors, nurses, and public health professionals join concerned elders to create content to be shared in upcoming months. Let us know if you are interested in this team. You can email us at info@eldersclimateaction.org. Today's webinar is the first program of our climate and health team efforts. We're incredibly fortunate to have Dr. Melanie Haines. Dr. Melanie Haines is an assistant professor of medicine at Harvard Medical School and an associate physician at Massachusetts General Hospital. She received her BA from Dartmouth College and her MD from the Johns Hopkins University School of Medicine. She then completed an internal medicine residency at the Brigham and Women's Hospital and an endocrinology fellowship at the Massachusetts General Hospital. She is an NIH-funded clinical investigator with research interests in endocrine dysregulation across the weight spectrum and its effects on body composition and type 2 diabetes risk. She is also interested in the effects of climate change on endocrine health, including the effects of extreme heat in patients with endocrine conditions and the effects of endocrine disrupting chemicals in our environment on body weight and metabolism. She is an active member of the Endocrine Society's Endocrine Disrupting Chemicals Special Interest Group, the Endocrine Society's Climate Change and Endocrine Health Group, and the Massachusetts General Hospital Center for the Environment and Health. She maintains a clinical practice in the Neuroendocrine and Pituitary Tumor Clinical Center at Massachusetts General Hospital. After Dr. Haines' presentation, we'll take questions and then we'll have an action party with Climate Action Now. So Dr. Haines, please take it away.
Thank you so much for the kind introduction, and I'm just so honored and delighted to be joining you all this afternoon or this evening. So I'm going to share my screen. So can you all see the top slide? Great. Okay, so today we're going to be talking about heat vulnerability across the lifespan, exposure, sensitivity, and adaptive capacity to extreme heat. I live in Boston, and we've already had 21 days over 90 degrees in Boston this summer, and the summer's not even halfway over. So this presentation is very timely, and I look forward to your questions and our discussion at the end of my presentation. These are my disclosures, which are not relevant to this evening's talk. I wanted to start with a case of one of my own patients that resulted in me being interested in the effects of extreme heat on health. This is the story of a 56-year-old man who was an international patient and was admitted after being found down in his apartment. He was last seen well 3 days ago at a doctor's appointment where he had endorsed increased urination. On arrival to the emergency room, he had an elevated heart rate of 120 beats per minute and a very low blood pressure of 80/40, and he was confused. Laboratory studies demonstrated that he was in metabolic disarray with a very high glucose level. And during this admission, he was diagnosed with both diabetes mellitus as well as another endocrine condition called diabetes insipidus, in which his kidney is not able to hold on to water. So at this point, you may be asking yourself, what does this case have to do with heat vulnerability across the lifespan? Well, Boston was in a heat wave at the time of his admission, and he was found down in his apartment on the 4th day of the heat wave here. As I mentioned, he was an international patient who was not acclimated to Boston nor its weather, and he was living alone in short-term housing without an air conditioning unit. Although extreme heat was never mentioned in his chart as a contributing factor to his hospitalization, I think that his exposure to extreme heat, as well as his lack of resources to cope with it, contributed significantly to his presentation. Unfortunately, this is not an uncommon story, as extreme heat is associated with significant morbidity and mortality. In fact, extreme heat is responsible for more deaths than all other natural disasters combined. It is estimated that 5,600 excess deaths per year in the United States are attributable to extreme heat, using analyses that associate daily temperature with mortality counts. In contrast, 700 deaths a year are recorded as being due to extreme heat in cause of death analyses. This discrepancy may be due to lack of standardized criteria for identifying a death as attributable to heat and missed cases where heat contributed to death from another cause. Extreme heat is also associated with a number of other adverse health outcomes, including increased emergency room visits, hospital admissions, adverse pregnancy and birth outcomes, and increased healthcare costs. And as we know, this problem is getting only bigger as the frequency, intensity, and duration of extreme heat is increasing. Historically, here in Boston, summers have included about 10 days over 90 degrees Fahrenheit. As I mentioned at the beginning of this talk, we've already exceeded that. And by the 2070s, we could be experiencing between 33 and 62 days per year that are over 90 degrees Fahrenheit, or more than half our summer, making this a significant public health issue. And this is why aggressive action is necessary to reduce the burning of fossil fuels and reduce carbon emissions. It's true that one's vulnerability to extreme heat is dependent on a few factors, namely increased exposure, increased sensitivity, and reduced adaptive capacity. In green here, individuals who have increased exposure to extreme heat include those who live in urban heat islands, which are urbanized areas that experience higher temperatures than outlying areas with fewer structures and more green space. Those with housing insecurity, outdoor workers, and outdoor athletes. In red here, individuals with increased sensitivity to heat include those who are less than 5 or greater than 65 years old, those who are pregnant, those with certain chronic medical conditions, which we will discuss, those with disabilities, and those on certain medications, which we will also discuss later in this talk. On this list, advanced age is the greatest risk factor for adverse heat outcomes. And in blue here, individuals with reduced adaptive capacity to heat include those who experience social isolation or financial insecurity, or those who lack a heat response plan or access to cooling. As I mentioned, heat islands are urbanized areas that experience higher temperatures than outlying areas. Not only are urban heat islands hotter than surrounding areas, but they also stay hotter longer. In the figure on the left, you can see that there's a 15-degree difference from 92 degrees Fahrenheit in blue to 107 degrees Fahrenheit in red in air temperature during the day between the coolest and hottest areas of Boston. And this is true in many cities across the country. In the figure on the right, you can see that this difference in air temperature persists at night as well, which is problematic as high temperatures at night mean that there's no opportunity for the body to cool down without air conditioning. There are also significant racial, ethnic, and socioeconomic disparities in how extreme heat is experienced across the cities in our country, including Boston, as urban heat islands with low tree canopy cover are concentrated in communities of color and lower socioeconomic status. You can see here that the areas that suffer from the urban heat island effect, shown here in red and orange, are also areas with a greater percentage of underrepresented racial and ethnic groups, shown here in the brick red color, as well as lower median household income, shown here in the white and light blue. Such disparities make these communities at higher risk for heat-related morbidity and mortality. This fact is evident in survey data as well. As part of the City of Boston's report on heat resiliency, Boston residents were asked, when it is very hot outside, how often do you feel too hot at home? While 24% of white respondents said that they feel hot at home, 36% of Hispanic or Latinx respondents reported that they felt hot. And 42% of Black and African American respondents reported that when it's very hot outside, they always feel hot in their home. In addition, outdoor workers have increased exposure to extreme heat. Physical exertion, uniform clothing, poor monitoring of the work environment, and productivity demands of the job all increase the risk of outdoor workers to extreme heat. In fact, farm workers are 35 times more likely than the general population to die of heat exposure. And unfortunately, there are no federal heat safety rules. There was a recent public hearing of Occupational Safety and Health Administration, or OSHA's, proposed standard on heat injury and illness prevention in outdoor and indoor work settings, but it's unlikely that a strong federal standard will be set in the near future, leaving it to the states and local governments to approve their own heat safety plans. In fact, some states already have their own OSHA-approved heat safety plans, including ones that I know of in California, Colorado, Minnesota, Oregon, Washington, and Maryland. I now want to turn our attention from people who have increased exposure to extreme heat to those who have increased sensitivity to extreme heat. Our body's response to extreme heat is complex and is a combination of thermoregulation or temperature regulation here in green, cardiovascular or our heart's response in red, and fluid regulation in blue. This is a very busy figure, so I'm not going to go through it in fine detail, but just to highlight the major points are that as our body's temperature starts to go up, our blood vessels dilate and we sweat, and the evaporation of the sweat from our skin cools our body. In order to keep our blood moving through these dilated blood vessels and cooled through the evaporation of sweat, part of our heart's response is to increase our heart rate. And in addition, sweating results in dehydration that increases our thirst so that we are triggered to drink. However, pregnant people have increased sensitivity to extreme heat, and this is because the body already produces more heat during pregnancy because of the increased metabolism needed to support fetal development, as well as the strain from the increased body mass during pregnancy. High temperatures, both ambient temperatures and high body temperatures, may result in reduced blood flow to the placenta, dehydration, and inflammation, which can cause preterm birth, stillbirth, and low birth weight babies. And we know that preterm birth and low birth weight have been linked to a range of poor outcomes later in life, including impaired cognition, reduced growth, and chronic health issues. So this is of great public health concern. We also know that children also themselves have increased sensitivity to extreme heat. This is because children, especially infants and toddlers, don't sweat as well as adults can. And in addition, infants also have a lower surface area to body weight ratio and, of course, can't verbally ask for water when they are thirsty. Lastly, children don't know how to recognize symptoms of heat-related illness, as well as and they don't understand how to keep themselves safe during extreme heat. Studies have shown that extreme heat is particularly detrimental to learning in children, as heat has been linked to slower cognitive function and reduced concentration ability. A nationwide study of 9th through 11th graders who took the PSAT showed that those students scored worse on the PSAT when they were exposed to more high temperature school days, defined as 90 degrees Fahrenheit or above, prior to the test. I would say that a lot of our school districts in our country are not prepared for extreme heat and don't have appropriate air conditioning to be able to maintain cooling within the school system. In addition to pregnant people and children, older adults have increased sensitivity to extreme heat due to impaired temperature regulation, impaired cardiovascular or heart's response, and impaired fluid regulation. So going through every physiologic change with aging is outside the scope of this talk, but I wanted to give one example from each category. So in terms of impaired thermoregulation here in green, older adults have reduced blood flow to their skin as well as a reduced sweat rate, which results in increases in body heat storage and a higher body temperature in the same setting as younger adults. In terms of impairments in the heart's response here in red, the elevations in heart rate that are needed during heat stress are blunted in older adults. And lastly, in terms of fluid regulation here in blue, older adults can't and don't feel thirst as well, which increases their risk for dehydration during extreme heat. In addition, older adults have higher rates of age-related chronic diseases that are affected by heat. These include higher rates of heart, lung, and kidney disease, psychiatric conditions, as well as diabetes mellitus and obesity, all of which we will now discuss in further detail. So in terms of heart disease, up to 90% of heat wave associated mortality is attributable to cardiovascular events like heart attacks. This is in part because increased body temperature and dehydration increase strain on the heart, and dehydration also may increase our predisposition to clot. Importantly, cardiovascular mortality increases with the longer duration of extreme heat. As you can see in this figure on the right, at different temperatures ranging from 90 degrees Fahrenheit in the yellow line to 95 degrees Fahrenheit in the dark red, cardiovascular mortality on the y-axis starts to really increase significantly around day 4 of extreme heat, or hot 4, and then further increases exponentially from there with subsequent days of extreme heat, as you can see on the x-axis. Individuals with lung diseases are also at risk for adverse health outcomes during extreme heat. This is in part because sunlight combines with air pollutants such as methane, carbon monoxide, and nitrogen dioxide, and volatile organic compounds to create ozone. So this is the process by which heat promotes ground level ozone pollution, and ozone is known to cause lung inflammation and injury. Therefore, heat and ozone can thus result in exacerbations of asthma, chronic obstructive pulmonary disease, and other lung conditions. Moving on to another organ system, the kidney. As I mentioned previously, dehydration during extreme heat increases the risk of kidney injury. And repeated episodes of dehydration and acute kidney injury in outdoor workers has resulted in chronic kidney disease and even dialysis. And this has honestly reached epidemic levels in some parts of the world, specifically in Central America. In addition, the kidney is also in part responsible for the body's balance of electrolytes. So the incidence of electrolyte imbalances also increases during heat waves as the kidney is affected. Individuals with psychiatric conditions are also at increased risk during extreme heat. This is because individuals with psychiatric conditions may have reduced heat awareness, impaired judgment, or limited behavioral capacities to cope with the heat. In addition, heat can contribute to sleep disturbances, dehydration, and altered neuronal function in the brain, all of which may negatively affect individuals with psychiatric conditions. In fact, studies have shown that higher temperatures are associated with greater hospital admissions for mental illness, as well as a greater risk of suicide. As an endocrinologist by training, I would like to turn our attention to two endocrine conditions that are adversely affected by extreme heat, namely diabetes mellitus and obesity. So first, for diabetes mellitus, extreme heat, as we've discussed, causes dehydration, and this can result in an elevated glucose or blood sugar level, which then further worsens the dehydration, and it becomes this vicious cycle of dehydration and elevated glucose levels, which can be life-threatening. However, low blood sugar levels are also possible in patients with diabetes on insulin, as extreme heat exposure can increase insulin absorption due to increased skin blood flow. Adults with obesity are also at increased risk for heat-related adverse health outcomes. For instance, in a heat wave in France in 2003, adults with obesity had a twofold increased risk of death compared to lean individuals. This may in part be due to the fact that adults with obesity have a lower surface area per unit body mass from which to lose heat or dissipate heat, and because of this, they exhibit a greater elevation in their core body temperature than lean individuals. In addition to certain chronic medical conditions that increase the risk of heat-related morbidity and mortality, which we discussed, the medications used to treat such chronic conditions can also increase risk during extreme heat. Medications and heat interact in three primary ways. One, heat can degrade or damage some medications, such as inhalers and insulin. Two, some medications can increase the skin sensitivity from sun exposure, such as doxycycline. And third, some, in fact, many medications interfere with thermoregulation and or fluid balance, amplifying the risk of harm from extreme heat, such as diuretics or water pills. However, most medications have not been systematically studied in this thermoregulatory context or in clinical trials, so there are really no true evidence-based clinical practice guidelines in this regard. In this table, I show some medications that interfere with thermoregulation and or fluid balance. Although going through each medication and its mechanism is outside the scope of this talk, I show this list just to highlight that this list of medications is long, and that the effects of these medications on heat vulnerability is honestly really rarely discussed right now between physicians and patients, but I think it should be. So, to summarize, we have gone through groups of individuals who may be at increased risk during extreme heat due to either increased exposure or increased sensitivity. And I would now like to think about ways that we can better identify individuals with reduced adaptive capacity to respond to the effects of extreme heat, and also think about actions that can be taken to increase their adaptive capacity. When I give a similar talk to healthcare providers, I encourage them to think about assessing their patients' exposure to extreme heat, as well as their patients' ability to adapt to it by considering incorporating questionnaires into their clinical practice that can assess risk factors for health harms from heat. One such questionnaire is here from the CDC. It's called Chilled Out. And knowing that clinical practice is busy, I encourage providers to at least be able to answer the following questions about their patients using the Chilled Out acronym. So C is for cooling. Does your patient have a working air conditioner? H is for housing. Does your patient have stable housing? I is for isolation. Does your patient have a neighbor, friend, or family member who can check on them during hot days? Because we know that social isolation is a risk factor for harm in extreme heat. L is for electricity. If a heat leads to a power outage, does your patient have a plan for their refrigerated medications or electronic medical devices? L is for learning. Does your patient check the daily and hourly weather forecast to know the hottest time of the day? And can they access the heat risk tool, which we'll talk about on a subsequent slide? D is for drugs. Does your patient take medications that increase risk from heat exposure? And lastly, out is for outside. How much time does your patient spend outdoors on hot days for work, sports, or recreation? If a patient with financial insecurity is identified who needs assistance paying for the utilities, I encourage providers to speak with their social work teams to assist patients in accessing utilities assistance programs, since using cooling appliances such as air conditioners can be prohibitively expensive. As I mentioned on the previous slide, patients and their providers should be aware, and we all should be aware of this new National Weather Service and CDC heat risk tool. It's an experimental color numeric based index that provides a daily forecast of the potential level of heat related risk up to 7 days into the future. The heat risk takes into consideration a few different variables. One is how unusual the heat is for the time of year, because we know that extreme heat earlier in the spring or the summer is more dangerous as the body has not had time yet to acclimate to the heat. The heat risk tool also takes into consideration the duration of the heat, including both daytime and nighttime temperatures, as unusually warm overnight temperatures can add to heat stress. And lastly, the heat risk tool takes into consideration if those temperatures pose an elevated risk of heat-related impacts based on historical data from the CDC. So the result, based on all of this information, is a color-coded system that ranges from green, meaning low or no risk, to magenta, meaning extreme risk. And at the bottom of the slide here is an example of a heat risk forecast from over a 6-day period. However, it's important to understand that this heat risk tool and this forecast may not accurately reflect the temperature that people are exposed to in their home or their community. For example, if they live in the top floor of a multi-story building without air conditioning, or if they live in an urban heat island, they're going to experience even greater temperatures and greater risk. As the heat risk tool is a new tool, few people may know about it. People are much more likely to be familiar with the heat index, which is the feels like temperature when we consider air temperature as well as humidity. Increased humidity reduces evaporative heat loss from sweating and thus increases the feels like temperature. So by way of example, an air temperature of 86 degrees on the x-axis with 90% relative humidity on the y-axis actually will feel like 105 degrees to our body. That's outlined in the green square here. And that actually has a very similar feel-like temperature to an air temperature of 98 with a much lower relative humidity of 40%, which also has a feel-like temperature of 105 degrees. However, the heat index does not account for sunlight or wind speed, as direct sunlight with no wind will certainly feel hotter than being in the shade with a breeze. One key component of staying safe in extreme heat is to have a heat action plan, which is a written document outlining strategies to reduce the negative health impacts of extreme heat. This screenshot is from the AmeriCare's website, which makes heat action plans for patients, providers, as well as healthcare administrators. And you can access these heat action plans at the website link below. I skipped ahead there. The CDC also makes heat action plans, which are disease specific, which is novel and unique. This is the CDC heat action plan for people with heart disease. So I wanted to walk through it. It's 5 different steps. So step 1 is they are largely applicable to people without heart disease too. Step 1 is to stay cool by checking the heat risk dashboard, as we just talked about, and appropriately altering your activity level for the level of risk. So for instance, on a yellow or orange heat risk day, if you're outside, stay in the shade, take breaks, and really only try to be outside during the coolest parts of the day. On red and magenta days, which are again the higher heat risk days, limit time outside as much as possible. Step 2 is to stay hydrated by drinking water, limiting beverages high in sugar, sodium, caffeine, and alcohol, so avoiding all those things, and making sure that your urine color is light yellow or clear, and talking with your doctor about how to manage fluids if you are given a fluid restriction or fluid prescription as part of your heart health plan. Step 3 is to check for heat-related symptoms such as heavy sweating, shortness of breath, dizziness, headache, fatigue, weakness, and nausea, and having a plan for what to do should those symptoms appear. These are specific symptoms of heat-related illness, and we'll talk about them in further detail on the next slide. Step 4 is to check the air quality because, as we discussed, heat can make air quality worse, and bad air quality can also worsen cardiovascular symptoms. So one way to check the air quality is to use the air quality index, which is easily found on many different weather apps. And it measures the air quality on a scale of 0, which is good, to 500, which is very hazardous. So depending on your underlying medical conditions, patients with cardiovascular disease may want to limit their outdoor activity if the air quality index is greater than 100. And the last step, step 5, is to have a medication plan because, as we discussed, many medications can affect thermoregulation and fluid balance, and the medications themselves may be detrimentally affected by extreme heat. So as I mentioned before, these next 2 slides go over the symptoms and treatment of heat-related illness. On the top part of this slide are heat cramps, which are painful muscle cramps or spasms that should be treated with rest, cooling down, and hydration. Heat exhaustion, unlike heat cramps, is associated with more systemic whole body symptoms like headache, dizziness, weakness, nausea, and should be treated more seriously with rest, cooling down, like moving into an air-conditioned area or taking a cool shower or putting a cool compress on your neck, and hydrating with water. Medical attention should be sought if symptoms do not improve. And then in contrast, heat stroke is a true medical emergency that occurs when the body can no longer regulate its temperature, and thus the body temperature rises rapidly, typically at or above 104 degrees Fahrenheit. Importantly, heat stroke can be preceded by heat cramps or heat exhaustion, or it can occur suddenly. So you don't have to go necessarily through the steps. Heat stroke can occur without heat cramps or heat exhaustion. Importantly, patients with heat stroke may not sweat because their body essentially is having end organ damage and sweating is no longer working. Older adults are at particularly high risk for heat stroke, and mortality rates can reach more than 50%. And this is a true medical emergency, so 911 needs to be called immediately. For people who are not able to stay cool in their homes and are at risk for heat-related illness, many cities now have cooling resource maps, such as the one shown here that's on the City of Boston website, where you can find locations for community cooling centers, spray decks, pools, and public libraries to get relief in your city from the heat. I was personally interested in expanding upon the City of Boston's work in extreme heat mitigation and adaptation by better understanding ways to improve community capacity to respond to urban heat. I collaborated with a wonderful organization called Communities Responding to Extreme Weather, or CREW, and we received funding from the MGH Department of Medicine Community Council. And we had two aims of our study. One was to develop an educational workshop to increase awareness about the health effects of extreme heat. And aim two was to evaluate the effectiveness of our educational intervention on whether it changed knowledge, attitudes, and behaviors around extreme heat. And we assessed that through surveys. So for these workshops, we partner with 3 different churches or community centers in the greater Boston area. The 3 churches or centers that we partnered with were St. Stephen's Church, a community center in Dorchester, and the Boston Nature Center in Mattapan. And we chose these locations because all 3 had long-standing relationships with CREW, which really enabled us to more easily engage with the community in planning the workshops and making a community needs assessment before each workshop to make sure that we were delivering what the community needed and wanted. We also were able to leverage CREWs and each community organization's social media contacts to really get the word out about the events. This is a sample program schedule. The workshop started with a welcome and a dinner, and during the dinner, we distributed a pre-event survey. We then had an educational component about how to stay safe in the summer heat that was delivered by Reverend Vernon Walker, who was the program manager for CREW, as well as myself. And then after that educational session, we distributed the post-event surveys during the Q&A session. We also raffled off over 30 air conditioning units across the 3 events. And the events ended with closing remarks, and all attendees received these free extreme heat kits, which included emergency waters, electrolyte tabs, cold compresses, and thermometers. The program was really well attended. Across the 3 workshops, we had more than 80 attendees, of whom 65 completed the surveys. And the average age of the survey respondents was 45 years, with more than a quarter of them being 60 or older. And it was a very diverse group of respondents, with 77% identifying as Black or African American. Our data from our surveys suggested that the workshops did change participants' knowledge, attitudes, and behaviors around extreme heat. And I'd like to share 4 examples with you. One question we asked was, did you prepare or will you prepare for extreme heat in the spring or early summer? After the workshop, over 85% of participants planned to prepare for extreme heat in 2022, which was the year that the workshops were done, compared to only 55% who had reported that last year. And then in the fall 2022 survey, 85% of participants did in fact prepare for extreme heat in 2022. Another question we asked was, did you or will you check in with family and friends during a heat wave? After the workshop, 100% of participants reported that they would check in with family and friends that summer, compared to fewer than 60% who said that they had done that the previous summer. And in the fall survey, the fall 2022 survey, 85% of participants did in fact check in with family and friends. And this was a significant I think a significant improvement. I believe that the power of leveraging social capital to improve the resiliency to extreme heat is a really important and powerful idea, especially among older adults who suffer from higher rates of social isolation. A third question we asked was, how many strategies did participants or will participants use during extreme heat? After the workshop, participants plan to use about 10 strategies to stay safe during extreme heat versus just 6 that they had used during the prior summer. And in the fall survey, participants did in fact use an average of 10 strategies to stay safe during heat. Lastly, we asked, what prevents you from using strategies to stay cool during extreme heat? And these responses I thought were really interesting, as upwards of 50% of participants reported that lack of time and or lack of money were significant barriers to preparing for heat, suggesting that increasing access to resources, particularly financial resources, remains an important consideration for future work. And although it was not significant, fewer participants did not think that they were at risk during an extreme heat event after the workshops, highlighting that the workshops met one of our intended goals regarding increasing awareness about the dangers of extreme heat for all of us. So in summary, we learned 3 lessons from the extreme heat workshops. One, that communities are engaged in learning strategies and are receptive to receiving resources to improve their resiliency to extreme heat. 2, communities are willing to leverage their social capital, including by checking in on family and friends to stay safe during the heat wave. And 3, lack of time and money remain significant barriers to implementing strategies at an individual level to improve resiliency to extreme heat. I think that there are a number of critical unmet needs for future heat policy. And I sort of wanted to end on this note and talk about a couple of upcoming projects in the Boston area, including my own group. So one critical unmet need is that we really need better surveillance of heat and its health and socioeconomic impacts, because we can't improve upon what we cannot measure and quantify scientifically. 2, we need to identify local and state leaders who will organize a multidisciplinary preparedness plan and response for our communities. Many cities now have these chief heat officers, which are city or state officials who are tasked with this coordination and implementation of strategies to mitigate the risks and impacts of extreme heat. This is I listened to a talk recently about from Arizona's chief heat officer, so it's much more common in the Southwest and the South. But I think it's something to consider across the country. 3, we need to consider classifying extreme heat events as a state of emergency in order to be able for local and state governments to be able to mobilize additional resources during such events that are associated with such high morbidity and mortality. And in fact, I would even go a step further and say maybe we should even name heat waves like we do tropical storms and hurricanes, as it may make people more aware of what's going on and may make them more likely to stay inside and be safe. It was interesting, in a recently published paper from Spain, a local heat wave was given a name, and the researchers showed that the people who could recall the name of the heat wave also said that they had engaged in more heat safety related behaviors during the heat wave. A fourth critical unmet need is we need more long-term impact reduction strategies to mitigate the risks of extreme heat, such as strategies to increase tree canopy and shade in our cities, installing cool pavements and cool roofs, and essentially trying to reduce the urban heat island effect. And last but of course not least, we need to address the root cause of extreme heat by reducing our dependence on fossil fuels. So 2 projects that I wanted to highlight and then conclude. So one project that will address the need for better surveillance of heat and its health impacts is a collaboration that I'm involved with at Boston University with Dr. Patricia Fabian and Dr. Madeline Scamell. BU has been collecting an impressive amount of daily street level temperature data in Chelsea, Massachusetts since 2015. And we plan to leverage that data alongside data from the electronic medical record system in order to investigate how urban heat islands affect acute healthcare utilization and whether neighborhood-specific interventions during extreme heat can reduce acute healthcare needs during those events. And of course, strategies that can address more than one critical unmet need at a time are even better. And this is why I think that the Boston Medical Center Clean Power Prescription Program, which is led by Dr. Anna Goldman at BMC, is very exciting. So, this is a pilot program that enables Boston Medical Center providers to identify their patients who might be in need of utility assistance and reduce their utility bill using renewable energy. This is done through the Boston Medical Center's rooftop solar array, which you can see here. BMC will allocate energy credits to individual patient homes, which will have a direct reduction on patients' electric bills. So I'd like to conclude with the following remarks on heat vulnerability across the lifespan. Our work has shown that community education holds promise to build both social capital and change knowledge, attitude, and behaviors around extreme heat. And as we know, extreme heat, which is increasing, is already responsible for more deaths than all other natural disasters combined. Vulnerability to extreme heat is dependent on one's exposure, one's sensitivity, and one's adaptive capacity to mitigate its effects. And I believe that healthcare providers should be assessing all of our patients for risk factors for health harms from extreme heat and providing high-risk patients with information and resources to keep them safe during extreme heat. And of course, aggressive action is necessary to reduce the burning of fossil fuels and carbon emissions to address the root cause of climate change and extreme heat. So I look forward to your questions and discussion. I just wanted to end by giving a special thanks to communities responding to extreme weather, as well as the Department of Medicine Community Scholar Award at MGH and the MGH Center for the Environment and Health, all of whom have been incredibly supportive in my work. Thank you so much.
And thank you so much, Dr. Hayes. That was very, very informative. We've got several questions. I think there'll be more questions coming up. If you have questions, please put them in the Q&A so I don't accidentally overlook them. There's a lot of interest in the idea of heat tolerance. For example, one person wrote that her heat tolerance is better. Well, she thinks it is because she grew up in the South playing lots of tennis in the summer, and she's wondering if she should encourage her daughter to make sure that her granddaughters play outside a lot as they grow to increase their heat tolerance. Is that a good idea?
Yeah, I mean, it's a great question. Our bodies, to a certain extent, can acclimate to warmer temperatures, again, to a certain extent. There is a temperature at which, even with no humidity, our bodies cannot really function. And that acclimation process, even in temperatures that your body can acclimate to, can take many weeks. I actually gave this talk a couple weeks ago during a heat wave in Boston and gave it to some students and found out that right before the talk, they had gone outside running at 12 o'clock when it was 102 degrees outside. And I was like, wow, did you know what we were talking about today? So I think, your body can acclimate to a certain extent, but I think it's always safer to, stay inside during the hottest part of the day, in part because that acclimation process takes a while.
Do we have any idea how long the acclimation lasts? I mean, some people are wondering, does it last a few weeks, a few years, the rest of your life?
Oh, that's a great question. I actually don't know. So I don't want to mislead anyone. I don't know it's interesting of my own patients, and my colleagues have experienced this as well. Patients don't come to appointments in Boston when it's really cold. Patients don't come to appointments in Boston when it's really hot, except like our patients who are from like Central American countries will still come to their appointments when it's really hot. So I think there probably is some, at least from a intellectual point of view, maybe there's some prolonged adaptation, but from a physiologic point of view, I'm not sure.
Right. So you mentioned earlier was an increase in kidney disease in Central America. And it was a question, could you say more about that?
Yeah, so this was sort of started at a case report level, and now I think it's much larger than a case report level. And they're sort of, it was called chronic kidney disease. I forget what the rest of the terminology was, but it was kind of like not otherwise specified. And
Mhm.
they were seeing it in agricultural workers who, through prolonged periods of presumed dehydration and acute kidney injury, they were presenting to medical attention with essentially end-stage kidney disease requiring dialysis. And it was, it's very, I personally have never had a patient like this, but it's of course, heartbreaking to see this because it's preventable. But the socioeconomic factors are very difficult to address. I mean, there are even reports that agricultural workers specifically choose not to drink because they can't take a break to go to the bathroom. Like they don't want to lose, they're being paid by how much they pick, and any break that they take, even to go to the bathroom, is less money on the table at the end of the day. So I think the priorities really need to change because in the long term, it's not in the employer's best interest to be losing employees to these, devastating kidney diseases. So it's been reported more in Central America, but there have been cases of it in the United States.
And you mentioned that there are a few states that have occupational health regulations on heat, which seems like something that every state needs. Any ideas about how we could advocate for that in the states that don't have it?
Yeah. Um, I think that, and I do think every state should have it. I think that part of the challenge, even in an ideal world, is that it is so, what is considered safe not only is dependent on the job, but also dependent on the person. And so creating, I think in such standards, there really needs to be a lot of flexibility and a lot of sort of two-way communication between employer and employee because it shouldn't be a one size fits all rule. I mean, I think some general guidelines about how often employees should be required to take a break, cool down, have a drink. But some jobs are much more physically demanding than others, but even the ones that aren't physically demanding, if you're outside long enough, like that's also dangerous. So it's not an easy answer.
Yeah. Another thing that's probably not an easy answer was about the increased risk for multiple medications and if there are resources that relate to that.
Yeah. So as I mentioned in my talk, I think this is really underappreciated among healthcare professionals, and I think part of the challenge there is that there's not clinical trial level data, evidence-based guideline level data, but even without that, I think we have to start acting on it. And I think the most important thing is just for physicians and patients to start having that conversation. Even if it's not possible, as it's often not possible, to change the medication itself, for at least the conversation to be had that for, patient XYZ is at higher risk because they're on medications. This is not some fault of their own. This is not, they can't drink enough water to get them out of this. This is a risk specifically because of the medications, and therefore they need to treat themselves differently than their peers, perhaps.
Yeah. So sounds like at least in Boston, some physicians are talking with their patients about these risks. Do you have any idea how widespread that is and to what degree people are connecting that to climate change and the need for climate action?
Yeah, it's certainly not as widespread as I'd like it to be. And I think you can often make, if you're at least thinking about the effects of climate and health, I feel like I can relate it to almost every patient I see. I actually saw a patient just this past week who has adrenal insufficiency, so their adrenal glands don't make enough cortisol, which in the setting of some physical stress like a heat-related illness could predispose them to adrenal crisis and shock. And I was asking him, I was like, "Oh, what do you do for work?" And he said that he was an outdoor worker, and just a few weeks ago, he was having really bad leg cramps and didn't know what to do because they were on this job site and there was no way to take a break. And I was just so shocked, and immediately knew I was going to share it with you all, because if I just hadn't asked, I mean, you have to ask to start the conversation. If I hadn't asked what he did for his profession, if I hadn't made the connection that I thought he was at higher risk for heat-related illness, I would have never been able to give him the counseling that honestly may save his life one day. And he was very grateful for that. He had never really made the connection. And it is once you know what the advice is, and once you have your support of your employer, to be able to do what is best for your health, it's simple to do. I mean, that's part of what's heartbreaking about heat-related deaths is that they can be preventable with the knowledge and the attitude and the resources to keep people safe.
Now, you mentioned the increased risk of a premature birth when the mother's exposed to high heat. If a baby is born prematurely, is that going to make the baby more sensitive to various things, particularly to heat?
I don't think there's necessarily, it's a good question. I mean, all babies are at higher risk for heat-related illness. I don't think it's something that is talked about with pediatricians. Some pediatricians are talking about it. Dr. Lisa Patel, who runs the Medical Society Consortium on Climate Change, she mentioned in a recent webinar that she talks about it to every single new family. She makes sure they have air conditioning. She makes sure that they know what to do. But for instance, and again, this is no fault of my own doctors, but this had never been discussed with me. And my son was born on June 1st, a couple years ago now. But I, because was armed with this knowledge, I knew what to do to keep him safe. And then he can't be outside. And just because he's not sweating doesn't mean he's safe, because babies don't sweat as much. So I do think that that pediatricians and OBGYNs are another group of healthcare professionals that can really help us in terms of arming the public with knowledge.
Right. Are you going to be able to share the slides with us?
Yes, I sent them to Paloma, so however they get distributed, I'm happy to share.
And we'll definitely send them out tomorrow. And most of our speakers do. I just wanted to check before I said that we were going to, but there are a couple of questions we're probably not going to get time to answer live, but that if people look through the slides, I should be able to find the information pretty easily. Um, what would you advise coaches in schools about student exposure to heat?
Yeah, I worry about this as a mom. I have a 5-year-old and a 2-year-old, and my 5-year-old goes to summer camps. And I honestly thought about what summer camps I was going to send him to, in part based on how safe I thought he was going to be there. And I think that is, I think that once kids get to be a certain age, the adults in charge, for lack of a better word, whether it's coaches or teachers or camp counselors, sort of assume that like the kid is going to stop playing when they feel hot, or get a drink of water when they feel hot. And I don't think that that is true at all, from my own personal experience. And I think that our school systems are not equipped to deal with extreme heat. I was actually just thinking the other day about reaching out to my town's school nurse to start having this conversation with her, so that I feel like my son will be safe when he goes to school in, September, and it's still 90 degrees outside. Um, so yeah, I think that is another area that definitely needs more increased awareness.
Uh, I'm in the Washington, D.C. area, and here and lots of places in the Mid-Atlantic and probably beyond that, we're having just not high heat, but also high humidity. It feels a little bit like living in a steam bath. I was wondering if you could talk a little bit about more of that combination of high heat and high humidity and how people should react to that.
Yeah, so I mean, this is so important. So high heat plus high humidity is so much more dangerous than just high temperature, because our bodies can't cool down. Our body cools down by sweating and evaporative heat loss. And if the humidity is really high, we can't sweat because we're already in a humidity bath. And so that is particularly dangerous. And so that is why checking things like understanding what the real feel temperature is can sort of clue you in, that, oh, well, my thermometer outside says it's 85, but the real feel is actually 105. And you need to act on the real feel temperature, not the ambient air temperature.
You mentioned about extreme heat being the most deadly natural disaster. Is that just in the U.S. or is that globally true?
Oh, I actually don't know for a fact that it's true globally. But I would imagine it to be, but I don't actually know that factually. I just know from the United States. I find those data very interesting, because as a physician, I'm a endocrinologist, but during residency, there was never discussion of any death being related to extreme heat, and I'm sure we were missing it. And I think that's borne out in the data that extreme heat is rarely listed as a cause of death, and it's really not until you look at the increased numbers of deaths related to every degree increase in temperature that you see the number of deaths that are actually attributable to extreme heat. And part of the issue too is physicians often just think about a death related to extreme heat if it's heat stroke. They don't think about this heart attack occurred because of extreme heat in someone who is susceptible to a heart attack, perhaps, but the actual, proximal event or that the proximal cause was the extreme heat event. So I think that is, I mean, I know there's a lot of medical schools now that have climate and health curriculum, so I hope that the next generations of physicians will be more attuned to these issues as they will have to be.
And I think we're seeing that these extreme heat events and the deaths related to them internationally, like in Montreal a few years ago. They really weren't prepared for that because it's not something in their climate that they were used to experiencing. They had a lot of deaths, and they weren't very good at doing what you're talking about and kind of teasing out things beyond heat stroke, looking at excess deaths from other causes, and then looking at more parts of the world. He's just getting unlivable at times. Um, so it really is a problem. It'd be interesting to know exactly there, but there's certainly other problems in those places, how they compare. Um, there was an interest in the hospital program for solar power for patients in need. I'm curious about how do they decide who gets it and how many people can they help with that?
Yeah, so as you know, I'm an MGH and this is at Boston Medical Center, so I know this through the media and then having spoken with Dr. Anna Goldman
Mhm.
and emailed with her once about it. But it is currently in its, my understanding of it is that it's currently in its pilot phase. So it's mostly being done through one clinic. And I think they have the initial sort of structure in place to be able to provide utility assistance to about 80 or 85 patients, I think. But obviously, my hope for something like that would be that it could continue to grow, not just through BMC, but through other hospital systems as well.
Somebody asked about many of us grew up without air conditioning in our homes or in our cars. And did growing up that way make us somehow more heat tolerant than growing up with air conditioning?
Yeah, so I think this gets back to one of the first questions that we start with in terms of how long does the adaptation last? I don't think that I don't think whether you had air conditioning or not as a child affects your ability now because the major difference is that it is hotter now.
Mhm.
Like you didn't need air conditioning 20, 30, 40 years ago, and now you really do to not be at risk. So I think your body's physiologic adaptations aside, it is a difference in our climate that's driving this.
Yeah, I think for simple, there's a behavioral component. Like I have a friend who doesn't have air conditioning in his house and doesn't seek it out very often. But he grew up in Texas, but he has a fairly elaborate system for when he closes windows, when he opens windows, the curtains, the fans, all kinds of things that he learned growing up in that kind of environment.
Yeah, and I
And
mean, some of this also speaks to like urban planning and infrastructure that in the Southwest, there has been, this has been something that has been a part of urban planning for many, many years. And so, from an infrastructure point of view, they are more well equipped than places in the Northeast, for instance, where this is a new concern and we're trying to, retrofit things that weren't initially created to be able to maintain habitable housing during extreme heat.
this has been fascinating and very helpful. And I'm sorry, the folks who I didn't get to their question, because we could certainly go on a lot longer to shift gears and get over to the action party. And Dr. Haines, you've been very generous with your time. If you'd like to hang out with us, you're certainly welcome to, but
Yeah,
we
I'd love to
really
hear what happens
appreciate it.
next.
Great.
Thank you.
Awesome. Well, I can jump in here and say hi from the Climate Action Now team. As always, we are super grateful and excited to be here with you guys to do this mini action party at the end of your national call. We've got a whole queue of extreme heat related actions for you to take this evening. So I'm just going to very quickly show my screen and give you a quick sense of how it works to use the Climate Action Now app. So you can take action super quickly by downloading the Climate Action Now app. You're just going to touch Do It Now. Then you'll get to select if you're calling or emailing your relative person who you're reaching out to. You hit send, and with those 3 touches, you've taken action. The really fun part about this, as well as many of you know, is that you earn points as you take action, and those points accumulate into real trees that Climate Action Now plants on your behalf. We've planted over 400,000 trees as a community at this point. So I'm going to pass it over to Kaylee Beam, the Director of Content at Climate Action Now, to get you started with taking action tonight. Over to you, Kaylee.
All right. Hello, everyone. Like Liz said, I'm Kaylee, CAN's Director of Content. Thanks so much for having us on these calls as always. I know it's a big highlight of my month, so really appreciate you having us on. I'm going to quickly share my screen and get us all ready to take some action together. And if you've been on these national calls before, you already know what you're looking at. On the left, we have this image of the Earth, which will fill in and iterate as we take action here tonight. And on the right side, we have this QR code box, which is what you're going to scan to get into the app. So all you need to do is go to your phones or tablets, open up your camera app, and point it right at that QR code box under where it says current action. As you're pointing your camera at the QR code, if you wait a few seconds, a little bubble that says Climate Action Now should appear. Once it does, just tap on it. Now, if you don't have the app already, tapping that bubble will take you to the App Store where you can download it for free. And once you have the app, all you need to do is follow the prompts to sign up, and it will take you straight to tonight's campaign on extreme heat. If it's not working for you, don't worry. You can also go to your phone browser and type in the link that's highlighted directly under the QR code, right where it says CanApp link/extreme heat. And we totally get it. If you prefer not to have another app on your phone, not to get on the app altogether, I will be dropping links in the chat that you can use to take action on the Climate Action Now website. So like Liz said, we have a whole slew of extreme heat related actions for you tonight. We have a couple petitions to media outlets focused on the connection between extreme heat and sleep apnea events. We have some actions focused on protections for outdoor workers. And then we have a number of actions focused on increasing urban greenery and the urban canopy. So yeah, I think you're probably all in there already. I'm going to stop talking so that I can start dropping those links in the chat. Yeah, thanks so much for having us on as always. Oh, thank you, Ariana. I see you're already on it.
Gotcha. So folks, if you are struggling to download the app, we do have some links that we're adding to the chat now, where you can more easily take action. One amazing way to take action tonight, and to help support programming like this is to contribute to ECA, to our programming. Right now, in the month of July, we actually are very fortunate to have a contributor who is pledging to double any donations made to ECA up to $5,000. So you could quite literally double what you give to ECA if you give to ECA. So I'm also going to put a link in our chat box to our donation page. Donations go to support programming like this, so we really appreciate it. And we would doubly appreciate it right now in this month. So please, if you have anything to spare, it'd be great. And I don't know, Francis, if you have a few more questions in the chat box. I know we still have our speaker Melanie here. We might as well take advantage of all of the time we are fortunate enough to get from her.
Let me find the questions again, and I will go back to them. So to point out, we have a lot of resources in the chat box. Don't worry about getting all of those because you'll be getting an email with the slides and with all the resources, which may answer some of your questions. One person commented that this would be a great program to be delivered by the Red Cross in community education. And I wonder if you had any thoughts about, how we could make this kind of outreach more broad.
This is a question to me, Francis.
Yes, please.
Yeah, yeah. Um, so yeah, I mean, I've thought about that with crew and my team at MGH in terms of how do we scale this, something like this. And it really takes a lot of people on the ground because I do think it's that personal touch and personal connection that makes the difference. I don't think that this type of intervention would have been as effective if it was delivered as a flyer in someone's mailbox, for instance. Um, and so, and I think therefore leveraging social networks and social connection, and I don't have a way to prove this, but my hope would be that a certain number of people come to an educational workshop like that, then talk to a certain number of people who talk to a certain number of people, and how many degrees of separation can you get? But I do think that because the effects of extreme heat are so numerous on our health, I mean, nearly every organ in our body, that um, um, any number of healthcare organizations, hospitals, nonprofits, community organizations should and could take an interest in this. And one of the things that I thought was unique about our program was that it combined, a hospital system, a nonprofit community organization, and the community themselves in terms of the planning and execution of the educational workshop.
That's a great thing, and hopefully that can happen much more widely. Someone was asking about the real field temperature. To what degree does that mean just how one feels about it, one's comfort, as opposed to the impact on one's physiology?
Oh, I would say it's both. I mean, you should feel more uncomfortable when the real feel is 105 compared to 85, but it's also reflecting your body's not, it will be more difficult for your body to, maintain its body temperature, maintain homeostasis at a real feel of 105 compared to 85, for instance.
So definitely some comments about people noticing things that hadn't made sense to them before, that blood pressure medications and why are they so much more affected by the humidity and the heat than they used to be, and the role that might play. And any advice to them about dealing with that?
Yeah, I mean, I think that the best thing, because we should never change medications without speaking with our prescribing doctors, to talk with your doctor about it. And I think maybe it's an opportunity, especially because oftentimes a medication is added and that it's never removed. And so having a diligent conversation between patient and physician about what is the purpose of this medication? Do I still need to be on it? Do I still need to be on it on this dose? If the answers to that are yes and yes, then how may I modify my activities, behavior to keep myself safe in extreme heat?
Mm. Yeah. That we've talked some about extreme heat and humidity, and certainly in the Mid-Atlantic region in New England, we're seeing a lot more of that combination. And I know you're not here as a climate scientist, but I was wondering if you'd say a little bit about why are we seeing those things together more?
Yeah, I think I did read somewhere that it is the Northeast that is warming faster than any other part of the country. I mean, we don't have the hottest temperatures, but in terms of the change over time, it is the most significant increase. And I actually don't, yeah, I don't know from a climate science point of view why that is. I'm wondering if it maybe has something to do with the currents and the and changes in the currents, because those largely impact our climate as well.
Yeah, and certainly, the hotter the areas, the more water it can hold. The whole idea of relative humidity, and sometimes I feel like we're living in a giant science project.
Mm-hmm.
We've talked a lot about the Northeast. Southwest is certainly experiencing a huge amount of this, and they're more experienced with this than we are. But I think they're experiencing things they haven't experienced in the past, like people falling down on the pavement and getting significant burns. And are you seeing any of that yet in Boston?
I have not heard of that, but I did recently read about very unfortunate situations and in fact scary that you could get a third-degree burn from falling onto the pavement. But there was actually the year I was giving these educational workshops with crew, a local news station reported that on the pavement at Boston Logan International Airport, you could actually fry an egg. The pavement was that hot. So I think that it is, it's certainly the extremes. I mean, the Northeast experiences a lot of extremes in terms of, I feel like in some respects the extreme cold is getting more extreme as well, in addition to the extreme heat.
Yeah, I have a friend who lives in Virginia who had to travel to the Southwest for work, and he has a service dog. And he was wondering why his dog was acting strange until he realized the pavement was so hot that it was burning his paws. And he had to actually pick up the dog and carry the dog to a safe place to be able to put him down.
Yeah.
Um,
Yeah. I know the Southwest has done a lot of work in this area in terms of cool pavements and cool roofs, in terms of making pavement with different materials. It's more reflecting the heat rather than absorbing it. And even in Boston, there was a small group that was proposing, painting roofs white instead of black. I mean, why do we have black roofs? Like, that is a terrible idea in terms of absorbing heat. And so it's I think every part of our urban planning and infrastructure needs to be reconsidered and thought about in this new lens of extreme heat.
yeah, certainly years ago, I lived in Vermont, and this kind of thing was just utterly unheard of, at least in northern New England. And now it definitely happens, but we still have, the houses and the pavement and everything that we put in those earlier days. We have to really think through how do we change those things.
I'll just
If
hop
I can
in
make
here
a
for
quick
second
comment.
and say we've reached our goal, which is always very exciting. So we hit 100. How much should we bump that up by, Kaylee?
I don't know. We only have 2 minutes left, so I think the ask is instead just keep taking action. Let's get that number as high as we can, everybody. Great work.
Heck yeah.
Yeah, in this last minute, if it's okay, I'd just like to
Please.
flag one risk, one concern to our community is, the heat injury from contact burns.
Mm.
Maybe there's a slight trip and fall. It happens in the elder community, but as well, and little ones learning to walk and whatnot. And in some communities, that burn can happen within 30 seconds. And if a person can't get back up quickly, then they've certainly got the potential for second and third degree burns. So be alert and really cautious, just walking to the mailbox, driving to the grocery store, make sure you're very steady on your feet.
We could certainly talk about this for a lot longer. But Dr. Haines, any last thing you'd like to say before we end?
Oh, this was wonderful. I'm just really honored to be part of this group and to share this discussion with you all this evening. And I now have the Climate Action Now on my phone, so I hope to participate in future calls. And thank you so much. In this time where of great uncertainty and potentially a lot of doom and gloom, it's just nice to be with a bunch of people who have shared concerns and goals. So thank you.
Yeah. Well, thank you so much. This has been a great presentation. We really appreciate it.